Hello and welcome to the fresh new episode of Oro-Otocerebral Pathway in development of cardiovascular system. Today we shall be talking about development of interventricular septum. After the cardiac looping and realignment of primitive chambers of heart towards the end of the fourth week, the inferior most part of bulbous cordis is partially incorporated into the ventricular cavity to form a common bulboventricular cavity. In this bulboventricular cavity, the primitive ventricle will actually form the left ventricle, whereas the bulbar contribution, the bulbous cordis, that part is going to transform itself into the cavity of right ventricle. So this newly acquired large size cavity, the bulboventricular cavity, starts receiving blood from both the atria and is pumping hard for the onward progression of that blood towards the outflow tract. In that attempt, the ventricular chambers expand more on their outward side or the lateral side. Thus, their medial walls start being compressed against each other and they become apposed and merge to form the muscular part of interventricular septum. So the beginning of primordium of this muscular part of interventricular septum primarily appears to be a passive process. The septum grows actively later upwards from the floor of the expanding bulboventricular cavity towards the conus septum and also towards the atrioventricular canals. The two ventricles communicate with each other via the opening between the free rim of muscular interventricular septum and the septum intermedium, which is formed as a result of fused endocardial cushions, and this communication is called interventricular foramen. This very time, the outflow tract of both the ventricles is divided by conus septum that contribute partially in the formation of interventricular septum. Proliferation of the septum intermedium closes this foramen and forms the membranous part of the interventricular septum. So the interventricular septum in its formation consists of three components: muscular component, conus septum component and membranous component. The muscular interventricular septum develops from the floor of bulboventricular cavity. The contribution from the conus septum, which divides the outflow tract of the two ventricles, contributes in it, and the membranous component is derived from the inferior endocardial cushion. And with contribution of these three separate but very closely placed entities, the interventricular septum forms completely and the two ventricular cavities are now in no more contact with each other. The rough part of each ventricle, which is inflow part, is coming from two different sources. The rough inflowing part of the right ventricle is derived from the lower part of conus cordis, whereas the rough inflowing part of the left ventricle is derived from the primitive ventricular cavity. The outflow part of each ventricle, though, is formed by respective halves of the conus cordis, which we have seen in the previous episode, how aorticopulmonary septum or the conotruncal septum shapes the outflow tract of the two ventricles and how it also helps in separation of the aorta from the pulmonary trunk. In the clinical anatomy of development of interventricular septum, we mainly have interventricular septal defects. They can be muscular ventricular septal defect or VSD. The muscular VSD is caused by single or multiple perforations in the muscular interventricular septum. There is another entity called common ventricle, which can also be termed as a cor trilocular biatrium. This is caused by failure of the membranous and muscular interventricular septa to form. A third possibility commonly seen is a membranous VSD, that is a membranous ventricular septal defect. This is caused by faulty fusion of the right bulbar ridge, the left bulbar ridge and the AV cushions. It results in a condition in which an opening between the right and left ventricles allows free flow of blood. A large ventricular septal defect is initially associated with a right to left shunting of blood, increased pulmonary blood flow, and pulmonary hypertension. One of the secondary effects of a large VSD and its associated pulmonary hypertension is a proliferation of tunica intima and tunica media of pulmonary vasculature, that is mainly the pulmonary muscular arteries and arterioles, resulting in narrowing of their lumen. Ultimately, pulmonary vascular resistance may become higher than the systemic resistance and cause the shunt to move from right to left and eventually leading to cyanosis. Well, this is as far as the development of interventricular septum and its relevant clinical anatomy is concerned. Happy learning!